So this is a very short talk, but I wanted to set the stage here with this because at the end of the day, when we assess our outcomes with patients, I think so often we've had our own biases based on the way either we were trained or we're using questionnaires or is it an exam and how does it look? And so these questions still come up in our minds today. What's the best measure? Are we using symptoms? Well, I hope we're thinking about that. Is it a bulge? Because bulge is one of the dominant symptoms that many women will complain of. And if that's their original complaint, hopefully we want to get a sense of whether or not that's the problem, in which case we want to resolve that. Is it an anatomical measurement? And are we just so fixated on the actual POPQ measurement? And I think for so many years we were so fixated on what the outcome was and using that. Or is it just overall satisfaction, which at the end of the day, if someone's vagina, as I think Kim said, may not look as pretty, but from a functional standpoint, it's doing everything you want it to do and is at it. Or are we back to physician assessment where it looks good to me, so if it looks good to me, that's all that matters? Or perhaps even the opposite. If it doesn't look good to me, then I think that patient needs to have another surgery, even though functionally they may be doing well and again, anatomically not as good. As Kim showed you with her original lecture, nearly half the women wouldn't meet the original NIH definition for optimal or satisfactory based on some of the staging that's been shown here based on Steve Swift's publication, where almost half would have some level of stage 2 prolapse or higher. So defining success, you need to remember a few things. There is some degree of loss of anatomical support, and that's normal. Many patients have affected quality of life and other scores that change minimally as they start to prolapse a little bit more. So symptomatic cure is probably more relevant than actually anatomical cure. And I think over history, we've really been too harsh on ourselves using anatomical success rates that are too strict and are not necessarily clinically relevant. So the big question still comes up, but what is failure after prolapse surgery? Again, is it retreatment, reoperation, is it complications, recurrence? So many of us now probably use some level of all of these, because if someone needed to have retreatment, but symptomatically they're better, what is that? Are they having a complication? Is it a mesh procedure that they now have had a complication for? Or do they have recurrence of symptoms because their original complaint was a vaginal bulge that didn't get any better or it came back, and now are they coming back to you for further management? Or is it an anatomical recurrence based on your definitions? Was it stage 2? Was it stage 3? Is it up to the hymen, beyond the hymen, et cetera? And so I showed you in my original talk about the Weber paper using the anterior colporrhaphy as the model. So anterior colporrhaphy in the standard suture-based way, adding an ultralateral suture and then adding a polyglactin or absorbable mesh. And when they looked at that using more clinically relevant criteria, success rates originally, and mind you, those success rates being so low for the traditional repair were used to be the basis for a lot of the mesh procedures, because they'd say, well, look how poor the success rate is here. You should use mesh, and accordingly, make the transition towards that, because we can improve upon this otherwise low success rate or high recurrence rate, depending on which way you looked at it. But now when we looked at this success rates based on different definitions, so now changing patients to no prolapse beyond the hymen, absence of prolapse symptoms, and no reoperations for prolapse repair. And this is one of my colleagues, Dr. Matt Barber, who did this paper reassessing this. You see the success rates change significantly now, up to 90 to 100%. So overall, patients looked at differently, their success rates change. But it doesn't mean that everything's okay, so you need to consider other factors. Is the patient now incontinent? So now anatomically you have a wonderful repair, but she's very incontinent. So that's not a very satisfied patient. Does she have sexual dysfunction? Because you did such a beautiful repair, you did a tight repair, she's not going to recur, but now she can't have sexual relations and she really wanted to. That patient may not be satisfied. Or does she have another sort of complication, mesh complication or defecatory dysfunction? So I think it's very important to reassess these goals. So talking to the patient, documenting that. In my sort of second job, I teach a communications class at the clinic. And one of the things we'll tend to go over more and more is, what are you looking for out of your repair in this case? So trying to get really the patient's assessment of what their initial impression is. So what are you looking for to achieve today? How is your quality of life being affected? So we'll ask about quality of life. What were you hoping to achieve from your visit today? Well, I was hoping to get surgery. Okay, so now I know what she's really thinking about, and then kind of get an assessment for that going forth. So again, just to conclude here, outcomes assessment, I think now, using POPQ in the hymen as a threshold for success anatomically is probably the more modern definition. I think subjectively, in absence of a vaginal bulge. Functionally, depending on your own level of interest, you can use other instruments in your practice, and that's your choice. But otherwise, something to consider functionally that the patient is improved. Sexual function, can you use various quality of life questionnaires and different things? And then again, assessing if they've had complications or other problems going forth, looking at other need for retreatment, pain, anything else like that. So you hopefully, again, appreciate there's just been some changes. We're starting to change this anatomical criteria more and more and using more clinically relevant criteria, and patient expectations and outcomes should be assessed at all times. Thank you. Go ahead. Okay. This is a
Hi, my name is Zila Abdul. I'm from South Africa, and I mentioned that I was a gynecologist. My question is, how do you deal with patients in your unit with regards to recurrent cystocele? We have many patients will come, well, few patients will come back with a recurrent cystocele. Do you primarily then revert to a traditional secondary repair, or would you then consider mesh? And if you do, would it then be abdominal or vaginal mesh placement?
I think we'll be able to address that. We have a case exactly like that for you. So
Yeah.
we'll go
That's
through
our
that.
first
Okay,
case, but that's a
our
good question.
Thank you.
Thanks for leading. Any other questions from the presentations so far? Don't be shy. We're a small group, so the idea is interaction. Elise.
Elise Day, Albany, New York. When you pre-place the sutures on the abdominal sacrocolpopexy mesh, then do they just sort of get dragged in with the mesh when you put it in? Does that become complicated or not?
No, we use colors, so we use blue and white, so I know which one is front and back. I put an arrow on the mesh, so I know exactly which one is the back one. And it just saves you some time because the knot is really there. You just have to pass them and tie the knot. So it's just a way to save a bit of time as opposed to get the whole suture, pass it through the mesh, and pass it through the tissues.
And the needles go in last and you just hand over hand them in?
Well, once I've passed, I cut the needle and then it comes out, yes. But you mean to get the mesh down through the assistant port? No, you just fold it and you grab it with a grasper and you have the sutures inside. So you roll it like a cigarette. And the sutures are inside and you bring it down. So,
Thank you.
Yeah.
So just, in the U.S. you can get this little pellet. It's about, just about the size of my thumb that you can just stick through a 12 millimeter port that has 6 sutures and then has a sharp container. So it's a great way. When I do occasionally do something robotically, I don't even have to use an accessory port because I just push that in through the camera port at the beginning of the case. And you have 6 sutures that can get all the suturing done you need to do on the suturing the mesh and the sacrum. So you don't even need people bringing them in and out, which is really fast. The only caveat is it only comes in Gore-Tex suture right now. So if you use delayed absorbable, it won't work.